Happy Friday, everybody. Another gorgeous morning here in Arizona. We have a bunch of procedures today, 3 procedures today. We had 3 procedures yesterday. We got to get in here and get rolling, but we'll sit down and do a recap and get some insight for you. Out the PRP, some Prolotherapy, another stellate ganglion. It is time, let's go. Hey everybody, so it is currently Monday. Last week ended up being a crazy week, Thursday and Friday. We ended up having a lot of procedures, a lot of stuff going on, and so I did not have a chance to film after those days. So in a few segments here, we're gonna do some of our recaps on the different procedures that we did, kind of talk through some of those things and try to help you out. So let's get going here. Alrighty, so our first procedure of the day on Thursday was a PRP procedure for a patient with cervical pain, shoulder pain, and low back pain. Now, we actually did an adipose stem cell procedure on her about 4 months ago, and she, across the board, has seen some improvement. She's seen about 30–40% improvement in her low back pain, but her neck and her shoulder were a little bit slower to respond. Now, one of the hard things with this patient is that she went from not really being able to walk half a mile without really bad chronic pain in her neck, her low back, and her hip, to now she's walking about 3 miles, 3.5 miles almost every single day. Now, she does still have pain with that. It's not like her pain is completely gone away. But one of the things that we sometimes see with these procedures is that the pain doesn't change overly much, but the activity levels that patients can do with that pain level is what improves. And so maybe before patients, an example, this case, she could only go for half a mile walk with her back pain and her neck pain kind of jumping up to a 6, 7 out of 10, a point where she would feel uncomfortable and would want to stop. Now she's able to get to about 3, 3.5, sometimes even 4 miles before the pain gets bad enough that she has to stop. And so that's the trend and improvement we're seeing. But she wanted to know if there was anything that we could do in addition to kind of help some of the neck and shoulder pain that hasn't fully, or not fully I should say, but hasn't appropriately responded the way that the other areas were. So we had her come back in, repeated a physical exam. Now, one of the big things I want to, that we stressed with her, and that I should say really came out in our physical exam, was that initially we really only treated the mid to lower facet joints in the cervical spine. So our first procedure, we did C3, C4 down through C7, T1. It ended up being on both sides because she had bilateral facet arthropathy or arthritis. Now, on the physical exam prior to her procedure on Thursday, what came out in that was that her lower facet joints were actually doing much better, but now her upper facet joints, so basically our C01, our C1, C2, C2, C3, those facet joints were what was causing her the most amount of pain at this point. And this sometimes happens where either initially on the physical exam, there was too much pain in the lower facet joint. So when we're loading the cervical spine to test it, we don't get enough stress into those upper because the lower take the brunt of the force, and then we don't get a full picture. What happens is the brain kind of shuts down some of the areas that it has pain because it's focused on other areas. And now that this part's healing, we're starting to get pain in the upper cervical facet joints. In addition to that, she also did have a fall kind of in between our stem cell procedure and our PRP procedure where she broke her elbow. From that, she ended up developing some lateral epicondylitis, which then moved into epicondylosis, became a chronic degenerative condition with some overlapping lateral antebrachial cutaneous neuralgia, or neurogenic inflammation and pain coming from the lateral antebrachial cutaneous nerve. So our procedure was pretty straightforward on the technical side of the equation. We did her sacroiliac joints. We hydrodissected the cluneal nerves in the low back. We also treated some past scars that she had from her fusion surgery that was like 25 years ago that didn't seem to be painful the first time around when we did stem cells, but did seem to be painful this time around. So we treated those. And then in the cervical spine, we really focused on the upper facet joints, making sure to get inside that joint capsule and then also around the joint capsule. We hydrodissected out the greater occipital nerve because of the pain pattern she was having that went up into the back of the skull, and then the tenderness and the palpable greater occipital nerve. And then in the shoulder, we retreated her supraspinatus tear and then also did some hydrodissections of some of the fascial planes in the area where some of the branches of the axillary nerve via the superior lateral brachial cutaneous nerve are piercing through and providing sensation to the anterior aspect of the shoulder. And so with that one, under ultrasound guidance, we basically went in between the deltoid and the rotator interval and hydrodissected that fascial plane to separate those two, again, to try and bathe a lot of the interfascial space there where a lot of those nerves are going to be present and passing through. Obviously, we retreated her tear, and then we moved to the elbow and we injected into the lateral epicondyle, so the common extensor tendon, and actually found a small tear that she had, which when we injected into that tear, we could see that tear kind of balloon out a little bit, which means that we got it in the right area. And then also hydrodissected the lateral antebrachial cutaneous nerve in its fascial plane, again, to try and help reduce the neurogenic inflammation and help the pain. And so overall, the procedure went really, really well. Obviously, the patient was a little bit sore, mainly in her elbow and her shoulder that night. But after talking with her today, she is doing well. And yeah, I'm really excited to see that one. And so we'll get back to work here, but then we're gonna come back and review some other cases with you. All right, so our second procedure on Thursday was a PRP injection for the bilateral feet. Now, this patient has a little bit of a complicated history in the sense that a little bit of his pain appeared to be inflammatory in nature, meaning it kind of towed the line of like a gout or a psoriatic arthritis, but the patient didn't really have classic gout or rheumatoid arthritis or psoriatic arthritis or anything like that. And so he was kind of getting tossed around by some different doctors, wasn't really getting anywhere with treatment options and things like that. And so he sought out my help on mainly the diagnosis and then looking for different things we could do for treatment. And so on the MRI, he had a few different interesting findings. He did have degenerative arthritis kind of throughout the forefoot and the tarsometatarsal joints, predominantly on the right side, which was his most problematic side. But the other really interesting thing was that he had a tear in the medial collateral ligament of the first metatarsal phalangeal joint, which I actually don't think I have ever actually seen that type of tear. And so with that tear, there might have also been a tear in the plantar plate, which is going to run under the undersurface, under the ball of the foot, which is where this patient was having quite a bit of his pain. And then our physical exam also showed that there was likely some lateral dorsal cutaneous neuralgia, so neurogenic inflammation and pain coming from the lateral dorsal cutaneous nerve, which is running on the outside of the foot. So this patient had both pain in the kind of the big toe region, but then a lot of his more acute pain had recently been kind of on the outside of the foot, following in that pattern of the lateral dorsal cutaneous nerve. And so we decided to obviously hydrodissect that and treat that. During the injections, the patient reported that we recreated his pain during the medial collateral ligament of the first metatarsal joint, as well as the plantar plate injections we did, which again, always is a big thing for me, that when we can recreate a patient's pain during these procedures, it makes us so much more confident that our diagnosis is correct and that we are on the right track for healing. Because again, it hurts to have an injection into a certain area. It's not fun to have a needle and some fluid put into different spaces. However, it's a different story and a different beast if we put the needle into an area that that is already sending pain signals to the brain, and then we inject a fluid into it. We get more pressure on those pressure receptors, and that can again recreate the signals to the brain that tell the brain that danger, danger, this is pain. And if that is in this familiar area to a patient, then it adds weight to the injections we did. So we are super excited to see how he heals, and we're gonna get back to it here, and stay tuned for our third procedure of Thursday. All right, everybody, last procedure of Thursday was another good low back case. So this patient had injured her low back the middle of last year. She was bending forward, grabbing something, twisted, it was a box, twisted, and felt a tweak in her low back. And then since then, she also progressed to develop, which was kind of, we think partly involved, but obviously still separate, is some lateral epicondylitis, which then obviously progressed to epicondylosis because it has been long-term, and we ended up treating both those areas. So on diagnostics, or physical exam for this patient, it was really clear to us that her sacroiliac joint was really inflamed, really irritated, so we would diagnose that with sacroiliitis with some overlying cluneal neuralgia. For her, it was mainly just the middle cluneal nerves that were inflamed, and the superior cluneal nerves did not seem to be problematic. Generally, when I have a patient who has that presentation where it's a flexion with a rotation injury, the kind of three main things that we think of is going to be a facet syndrome, so tweaking the facet joint, irritating the capsule, an acute sacroiliitis, or a superior cluneal neuralgia. Less commonly we see the middle cluneal neuralgia, but in this patient we obviously did, but superior cluneal neuralgia is usually the top priority, or not top priority, but in terms of between the middle and the superior, it's usually the superior. A lot of patients think that when they do this, when they have these little back injuries, that they're throwing out a disc, they're throwing out a back, they're slipping a disc. And while a lot of these patients will have an MRI that shows they have a disc bulge or a disc herniation, it is my opinion that usually a lot of the times that's not what is happening. Those herniations and bulges are generally chronic, and what we are seeing in these more acute cases is that we are seeing facets, sacroiliac, or the cluneal nerves that are being entrapped, damaged, and then therefore causing pain. So we hydrodissected some of the cluneal nerves. We treated the sacroiliac joint, which is probably one of our top low back procedures for sure, just because how common sacroiliitis is. And then we also treated her lateral epicondyle for the epicondylitis, epicondylosis. And just like our patient earlier in that day, we also hydrodissected out the antebrachial cutaneous nerve because of its involvement in the pain presentation in that area. And all of these areas recreated our patient's pain, which, as I said earlier, is exactly what we want. So that's a recap on Thursday. I'm gonna head home here on Monday. We're gonna come back here, and then we're gonna recap everything that happened on Friday. See you later. All right, everybody, so we're gonna recap the procedures that we did on January 29th, the Friday of Fridays at RP. We had a busy day. We had 5 procedures that day. So I'm gonna briefly talk about a few of them and then go a little bit more in depth into one of the cases, which is gonna be a case of some cervical neck pain with a little bit of instability. So our first case of the day was a patient who we have treated before for some pain and instability in the temporomandibular joint. We have done prolotherapy and PRP in the past, and we have gotten the patient to a place where she is out of pain. She just still has a little bit of instability and some popping and clicking, mainly in the left temporomandibular joint, a little bit on the right as well. And so we repeated with some dextrose prolotherapy, both inside the actual joint and then also into the supporting ligaments, the joint capsule around the joint, which provides a lot of that stability. And when we have instability, usually it's mainly coming from those areas. It's now been a little over a week since that procedure because we're late on filming this, and she reports that currently the popping and clicking is now gone, and the instability is no longer there at this point. So we will continue to monitor to see if it comes back, which usually when we get to this place, it doesn't, but continue to monitor and go on from there. So our second case is a patient who has had some low back pain and also some cervical neck pain. Now, the low back pain was pretty straightforward on physical exam. We had several different findings that were positive for sacroiliitis or some inflammation, irritation of the sacroiliac joint with the supporting ligaments around it, mainly the posterior sacroiliac ligament, which is commonly painful and contributing to patients' pain when we have sacroiliitis. And then in the neck, this patient had sustained an injury in jiu-jitsu where they were placed into a forced flexion position and had injured their neck, I think it was about a year ago or so. And while it has slowly improved over time, they were at a place where they didn't feel like it had fully improved and still had some pain with certain movements and things like that. And so we did some PRP injections just into the interspinous ligament and the nuchal ligament, which are going to be the ligaments that are going to connect all the spinous processes upwards towards the actual occiput. So the interspinous and the supraspinous ligaments are going to start all the way in the low back. Interspinous ligaments is going to be between each of the spinous processes, and the supraspinous ligament kind of runs on top. When we get up into the cervical region, that becomes the nuchal ligament, where the nuchal ligament will actually extend out backwards on the back side of the neck to attach onto the skull, but still continuing down and being the interspinous ligaments in between the spinous processes. And so we treated that with PRP in hopes to help repair some of the ligamentous strain that he had from that injury. So that was our second case. Third case is a repeat stellate ganglion and cervical sympathetic chain block. Which, if you watch the previous week's episode, you will have seen that we performed this for a patient who has stress-induced hyperglycemia. So this was our second procedure. So now we're going to track him for upwards of about 3 months with his CGM data to see if we notice a trend in his blood sugars, his A1C, and then we're also going to be repeating some fasting insulin levels over those 3 months. I'm super curious to see what happens with this patient, and I hope we're able to kind of get some insight into how we can help reduce his type 2 diabetes that appears to be very driven by stress. So that's going to be an exciting one. So our fourth procedure is the one that I wanted to talk a bit more about. So we had a patient who was having some left-sided cervical issues. It wasn't really a lot of pain. However, it was more so a little bit of instability and some popping and clicking somewhere along the articular pillar on that left side when the patient rotated and looked over the left side. So when we think about the anatomy of the facet joints in the neck, when we look over the left side, what's actually happening is the left-sided facet joints are opening up a little bit. Their rotation is such that the IAP and the SAP are going to gap a little bit. And if there's some instability in the joint capsule, that could be occurring a bit more than what would be normal or natural in the area, and that could be due to past injury, car accidents, things like that. Our physical exam suggested that there might be some instability in the joint capsule of the facet joints, and so we went in and treated both inside the facet joint and around the facet joints with PRP, and recreated the patient's pain during this, which again is always super important when we're doing these procedures, is that feedback with the patients on how does this feel? Does this just hurt because I'm injecting something there, or is this familiar to you? Is this recreating some of the pain that you would like to go away? Those things are really crucial for us because it gives us insight into our thesis, our diagnosis, which is a hypothesis, and adds weight to that as we're going through this process. So that's one that I'm really looking forward to see how she does. And the last case of the day was one of the students here who has been helping us out, and he's been having some sternoclavicular joint issues. He, I believe, had a prior separation, and ever since then has just had some chronic pain here, especially when running, as that SC joint is supposed to move and expand a little bit with the forced expiration and inspiration, and so was having some pain there. Because of some fascial adhesions also on the anterior aspect of the sternum that we palpated, we end up doing an anterior pectoral fascial plane hydrodissection, and then also treated the sternoclavicular joint with PRP. It's been now, I guess, a little over a week, and the patient already reports that while running, the diaphragm is able to open up a bit more, breathing is a lot easier on longer runs, and a lot less pain over the sternoclavicular joint, and it doesn't feel as unstable whereas it did before. And so that is our recap for our January 29th procedures. Thank you so much for watching this week's episode. I know it's a longer one because we had a lot of procedures. Please leave a comment below. Tell us what you liked, what you want to see less of, what you want to see more of, so that we can continue making these better for you guys. See you later.